No matter the size or shape, they all need to be checked. Call 0860 283 343.
Do check your breasts because early detection of cancer saves lives. Now, worldwide, every year more than 2 million women are diagnosed with breast cancer and around 800,000 die from this disease. Now, breast cancer is the leading cancer affecting women of all races in South Africa, accounting for approximately 1% of all deaths. Now, according to the National Cancer Registry from 2014, 1 in 27 women, or approximately 19.4 million women aged 15 years and older, are at risk of being diagnosed with breast cancer in their lifetime. Now, the good news is that breast cancer is preventable and treatable through screening, early diagnosis, and appropriate treatment. Our topic for today, therefore, is breast cancer. And to help us unpack this, we have a panel comprised of the Chief Director for Women and Maternal Health from the National Department of Health, the Head of Department at the Helen Joseph Breast Clinic, a specialist clinical and radiation oncologist, a general practitioner, a clinical health specialist from the Cancer Association of South Africa, and 2 breast cancer survivors, one of whom is a government campaign ambassador, and these will share their personal stories with us. Now, be part of the show by asking the panel some questions or simply just sharing your views with us. The number to call is Johannesburg 714-5861 or 5877. You can also tweet us at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Selomot Daung, and this is Health Talk.
What was the reason behind the establishment of the Pink Drive NGO?
We're 10 years young, and I realized more than 10 years ago that we had to try and make a difference in cancer, in the cancer space. And hence, the easiest way to make that difference was to build mobile trucks and take health to the indigenous population where there are no decent health facilities.
How does Pink Drive perform its cancer programs?
So there's sporting events, we work very closely with Corporate South Africa, where they invite us to come to their offices, etc., and we provide the screening services. And we focus on 4 gender-based cancers. One naturally being breast cancer, where we do mammography. The other one is cervical cancer, where we do pap smears. Then there's also the PSA screening for men for prostate cancer. But one must never ever forget that men also get breast cancer.
What is the significance of the screening for breast cancer?
Well, it's not just screening, it's education. And remember, we live in a country where obviously there's lots of different nationalities, different communities of people, and there's huge myths and stigmas that need to be addressed. So for me, over and above the screening, the education is the key part. And that is why we realized we have to start with grade 1, okay? Yes, we don't go in depth with the little ones, okay? But we teach them healthy lifestyles, don't drink, don't smoke.
Lack of funding by the National Department of Health for this NGO has seen them not being able to assist provinces faced with oncology crises.
You spoke about KZN now. When the previous MEC, who knows me personally, okay, I had umpteen discussions with him to say, help us bring the service to your province, because mammography is the diagnostic tool of the breast cancer. So mammograms need to be done before surgery can get done, before treatment can get administered. Give us, or allocate, not give, allocate funds that we can come and work in your province. You know, I've had numerous discussions with the previous Minister of Health. I've been to Dr. Yogan Pillay, who's responsible for the cancer health programs at National Department of Health. But for me, the most tragic thing is it seems to fall on deaf ears.
All right, we're going to unpack all of that, and later on we're going to be joined by someone from the Department of Health to perhaps respond to some of those allegations. But now, it's a great pleasure to introduce our special guest for today, the very well-known breast cancer specialist, Professor Carol Ann Ban, who is HOD at the Helen Joseph Breast Clinic and is also based at the Millpark Breast Clinic. Welcome to Health Talk.
Always a pleasure. Good to see you.
All right, great to see you again. And of course, next to her is Nonhlanhla Duba, who's the health cancer specialist, clinical health specialist based at the Cancer Association of South Africa. Welcome to Health Talk.
Thank you for having us.
All right.
Thank you.
So perhaps let me start with you to learn a little bit about cancer,
Yes.
you know, against the backdrop of what we've just heard now about NGOs and so on. Just give us a sense of what cancer is and what you guys do.
Okay. Cancer Association of South Africa, briefly called CANCER, is a cancer consent organization that is it has been there for almost 90 years now. And then the main thing that we work with, we work with research institutions to support research related to cancer because of the need for improvement of cancer care, as we know. And then we've got a very big role in care and support of patients and families that are affected by cancer. Because we've got care homes that are around nationally where we house people that are on treatment, because we know that the cancer treatment centers are very few in South Africa. Find people coming from Mpumalanga or Northwest coming to Gauteng for treatment, but they don't have homes around Gauteng. So we house them whilst they are on treatment, giving them a home away from home and transport to the care facility. And with that as well, we also run campaigns nationally, campaigning, trying to raise awareness as much as possible about cancer and the fact that cancer, there are risk factors that can be applied.
Okay.
Or maybe
so you educate people around it.
People.
So specifically around breast cancer, any activities perhaps that you have?
Actually, whatever that I'm saying also applies with breast cancer as well.
Right.
The screening that we do is also encouraging people to know their breast, to do breast self-examination. And we work in collaboration with partners, where when we've assessed patients that have got problems, we refer to them. For example, the breast unit at Helen Joseph, we work very closely with them. You know, even the treatment centers like Charlotte Maxakes, like your Steve Bikos, we work closely with them with the supportive role that we provide for the breast cancer.
And who funds you?
patients.
Last question.
Well, the funding is a challenge. We're not funded by the National Department of Health, but we are funded maybe through our activities, the events also that we raise funds with. And some of the screening where people can be able to pay for their services. So we actually do fundraising with our activities, even to corporates.
Okay. Let's come back to our subject for today, breast cancer. Firstly, before we describe what it is, I shared some figures around, you know, prevalence and incidence and so on. How common is this problem?
So I think breast cancer currently we think is the commonest cancer affecting women in this country. Remember, it's difficult to determine actual numbers because we don't have confirmed screening programs. So I can just reiterate, you've got to know your body, know your breast and know your numbers. So 65% of women who actually get breast cancer have no risk factors. So whereas it's very easy to say, don't do this and do this and do this, you need to fundamentally take responsibility for your body, examine your breast, know in terms of what's going on, and then make sure you can access services. So I have huge admiration for the Cancer Society in terms of what they do, so support Kappa Cancer, that type of thing, because patients come from all over the country to Helen Joseph, and then if they need chemo at the Gen or somewhere, they get housed and looked after. So we really have to work together to make people aware, but also tell them where they can access the services.
Okay, so we talk about breast cancer.
Yes.
We spoke earlier around, you know, we're saying women,
Yes.
but we heard in the clip that men
Men.
can get
Yes.
breast cancer as well.
I love my
So
men.
who gets breast cancer?
I have lots of men with breast cancer. I've actually seen an increase. So sub-Saharan Africa has probably one of the highest incidence in the world. It sits at about 1 to 2%. So again, you've got to know your family history, because male breast cancer is associated more with genetic predispositions, such as the BRCA2. So we see 25% of all people who get breast cancer have family history of breast another. So prostate cancer in a man, particularly a younger man, 60s and 50s, will translate to a high incidence of breast cancer in a woman, okay? So we've got to be aware of that. 10% count for the single gene mutations like the BRCA1 and BRCA2. But again, vast majority of people, the 18-year-old who they're flying in for me next week, no family history.
And in terms of age in women, what
So
sort of ages are we looking
from
at?
18 to 110.
Yeah.
So usually you are more likely to get a cancer as you get older. So 1 in 4 people over the age of 70 is more likely to have a cancer. But we can treat cancers, and we're seeing better survivals internationally because people are coming in earlier. So that's what we've got to push with our ladies. That 27-year-old with the lump who someone says, it can't be, it can't be. We don't have eyes on our fingers. You come in, and where I'm in a little disagreement with the clip, the equipment is there in the government units. So doctors have to take responsibility. We have to work hard, proudly do what we do in the government service, and take responsibility. Fill in a form, send the patient for that mammogram and that biopsy, and then go over the results. Got to be careful, too much out there, then people don't know where to turn once they have a concern.
We're going to come back to all of those issues around screening and so on. But let's just come back to, I'm sure people watching may say, okay, so how will I know if I have breast cancer? What are the clinical features?
So basically, ladies, you take your top off in the evening and you stand naked and you lift your arms slowly to the side. You want to see that nothing's pulling your nipple in or any changes on your skin. You then use the flat of your hand, your 3 fingers, feel gently. I'm surprised how rough people are with the breast examination. Gentle examination, and feel gently in your armpit or your axilla. When you go for your sonar, they lift your arm above your head. Don't do that when you examine your breast. And it's about feeling the same thing every month. As soon as it feels different, or you have a leak from your nipple, don't squeeze your nipple. If something doesn't feel the same as it did the previous month, then you go for your checks.
Right. So it could be a lump, it could be
Redness,
something coming out of the nipple.
Absolutely. So something that's not the same as it was, go and see a healthcare provider. Make sure they refer you for the correct investigation. A sonar if you're under 35, ultrasound, mammogram and ultrasound if you're over 35. And we have
So without
access.
getting too technical now, how do you diagnose it? We hear of stages, stage 1 up to stage 4 and so on.
Okay, so basically when you feel something concerning, you come in, either on an ultrasound or mammogram, you do a needle biopsy. I want to reiterate the diagnosis of breast cancer should not be made by a surgeon cutting. We do a needle biopsy, we take a sample of the cells, they look at the cells on the microscope, and they tell us what the nature of the cancer is. Today it's about precision medicine more than stage. So you can have people with stage 4 cancer who can live for many, 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 many years if you've got them on the right treatment. Think of oncology as antibiotics for cancer. The right antibiotics for the right cancer. And we have many drugs available. So it's not recipe, and that's why people mustn't say it's too late, there's nothing they can do for me. Please come in.
We have some people that are going to be joining us to tell us about their own personal experience. Some of whom have had what they were told is stage 4 cancer.
And they're still around.
But for now, we're going for a quick break. We'll be back soon.
I was diagnosed in 2016 with breast cancer, metastatic. It's HER2 positive. It's been quite a journey, actually. Good and bad things have occurred. It was a very tricky time in my life. In 2016, I had just started my own consulting firm. So, you know, with your own business, there's a lot of anxiety and stress. I honestly believed I had an ulcer, and I went to see a GP. She said, you know what, Joanne, we can't just diagnose an ulcer by looking at you and looking at symptoms. Let's do a scan. And the bloods came back, and she referred me to an oncologist. And I saw this doctor, and she was very curt. You have stage 4 breast cancer. It started in your breast and it's moved to your liver. There's a tumor on your spine. You know there's no cure for this disease, so it doesn't look good. I switched oncologists twice until I met Dr. Carol Ben, and she spent an hour with my family and I, just breaking down and explaining what I would have to go through, what this disease entails. When we left her rooms, there was a clear plan. I landed in ICU with septicemia. That was the worst time of my life. You know, my hair falling out, my skin going blotchy, my nails turning black and lifting. I'm on a catheter, so I can't go to the bathroom and do anything for myself. That's humbling. Having someone else wash you, oh my Lord, that was a lot for me to deal with. But you leave ego out of it, and you take things one day at a time. I am very vain, I'm not gonna lie. You know, cancer robbed me of what I held dear, you know, how I look and how I present myself and hold myself to the world. My hair grew back, my eyebrows, my nails. I dropped the water. I love working out and running especially. I did my first one step at a time walk, and we had branded t-shirts saying Joanne's battle is our battle. And I was on a complete high. For the first few months, I found myself saying, I am fine, I am fine, I am fine, a lot, because I was very concerned about how everyone else was taking this news, and also seeing me like that is exceptionally hard on the people I love and who love me.
Very inspiring story indeed. So breast cancer isn't a death sentence.
Absolutely.
Of course, there was mention of meeting Dr. Carol and Ben. Of course, she's with us today. And we're joined by two other special guests. The lady in the middle is Johanna Francis, who's a breast cancer survivor and is going to share her personal story with us. Welcome to Health Talk, Johanna.
Thank you very much.
Right. And we also have Dr. Manala Makua, who's Chief Director for Women and Maternal Health from the National Department of Health. Welcome to Health Talk, Dr. Makua.
Thank you very much.
All right. So perhaps let me get back to you. I mean, obviously, you know, you saw the clip of a patient of yours that you've treated. But let's come back to, because here I want to talk about the impact that breast cancer has.
Huge.
But before we do, let's talk about risk factors and causes. I mean, I know we touched on it a little bit in terms of family history and so on. So perhaps let's start from family history.
So I think Joanne is a prime example of someone with no cancer in her family, and she has symptoms and she goes to a doctor. And I think we must be so careful when we label people. So she had no risk factors. She couldn't even find a lump in her breast. She's big-breasted, and there was a deep little lump there, and it was a type of cancer called a HER2 positive, which really even stage 4 today we can treat or give people longevity, which is really all we want, quality of life and an understanding of what's going on. So I think it's that concept that there are no risk factors. Obviously, watch alcohol, watch prolonged use of contraceptions and HRT, exercise if you can, but know that it's not, it's a lotto of who can get what. I mean, I've got an 18-year-old with HER2, they're flying in now next week. So the fact of the matter is, know your body, okay? These are changes happening in your body all the time.
Yeah.
I think people undergo stressors, and when you have stressors,
Yeah.
your cells undergo change.
It's
And
interesting
things-
you mentioned some of those lifestyle-related
Yes,
issues that,
yes.
you know, lack of exercise.
Absolutely.
How about smoking? I mean, is
Smoking, cut down, no smoking, cut down on your alcohol,
Yeah.
watch your BMI, okay?
yeah.
So you try and control what you can control.
Right.
Okay, I always say don't be too hard on yourself, you know. There's no perfect person. If you're going to have that piece of cake,
Yeah.
don't beat yourself over the bush that that's why you got your cancer.
Yeah.
But try and have a sensible approach to life of things in moderation.
Okay. Dr. Mako, I'd like to obviously chat to you a little bit to understand exactly what, you know, programs the department has around breast cancer. But before that, I'd like to just speak to our special guest today, Johanna. Johanna, thank you so much for, you know, being willing to share your own personal story with us.
Thank you.
Let's just go back a little bit. I know that this happened to you a few years ago. Tell us when you were first diagnosed with breast cancer. What were the circumstances around that?
I was first diagnosed in 1999 when I was 37.
Yeah.
And no pain. The breast was just very hot. And I was lifting my left breast up and stroking over my breast, and went into the bathroom and, you know, lift up my arms and check. And then there was the lump was under the nipple.
Right.
And I made an appointment with a gynecologist because I was diagnosed in 1999, the 1st of September.
Right.
May of 1999, I went for an ordinary general gynecology checkup, pap smear, and the breast was also being checked. But that morning, I discovered that lump.
Right.
And biopsy was done, mammogram, and
They confirmed it.
it was confirmed. Yeah.
Okay. You weren't told about this staging issue?
It was stage 1. The lymph nodes were not involved,
Right.
but I had a radical mastectomy
Okay. And on one of your breasts?
on the left side. Yeah.
Right.
In 2003, there was a local recurrence
Yeah.
because there was a thickening on the cut line.
So just let's go back a little bit to around the time that you're now diagnosed with breast cancer. You're facing this prospect of having one of your breasts removed. Just take us through how you felt at the time and how you dealt with that.
Emotionally, I was very angry because I thought I've done everything in the book. I didn't smoke, I didn't drink alcohol, and I breastfeed all 3 of my children until the age of 2. And trying to look for, you know, for answers. Where does this thing come from? And, you know, in the olden days, the grandmothers and aunties were sick, but you never asked them, why do you have this blanket over you and all that? I only realized that my late grandmother from my father's side had breast cancer. And because I was the only person that spoke out about this thing called breast cancer, we started to, you know, shop around to look for answers.
Right.
And then I realized my father's brothers, their daughters are also diagnosed with breast cancer. And some of them died because of the ignorance. They died. I have another sister that was also diagnosed in 2007. She's fine because of the education that was already come from me.
Okay. So I believe you then had a recurrence.
A recurrence.
So you had the left breast removed.
Yes.
Okay. And what happened?
Okay. In 2003, on my birthday, I realized that also, you know, from checking, looking at the old wound, and because it was very tight now, and I was again stroking over it, and I felt the thickening, abnormal thickening. And once again, I went to somebody else because my doctor was out of the country, so I went to somebody else. And the person asked me, what are you going to do if the cancer is back? So I asked him, what do you want me to do if the cancer's back? I told him that day, I will deal with it the way I dealt with it the first time. Because I had all the support from my husband, my children, even if they were, at the time my daughter was 16, I had a 13-year-old son and I had a 7-year-old son. But the support was there because I set them down.
Okay. So obviously it was confirmed.
It was confirmed.
What treatment did you have on the left side?
What they've done on the left side, they once again just scoop out, and then I dealt with chemo for the first time in 2003.
Okay, before we run out of time, I believe you also developed breast cancer on your remaining right side as well.
Yes.
And when was
that? Diagnosis was made in 2016.
Yeah.
Once again, a thickening on the right breast.
Right.
And I went to check it out.
Yeah.
And a core biopsy was done and they confirmed it. But before that, I noticed that the right breast, the remaining breast, was abnormally larger than the other one.
Yeah.
And one of the doctors said, let's do a breast reduction.
Yeah.
So I said, no, I'm too old for that. Take it off.
So you insisted on a bilateral.
So
and how are you feeling now? I mean, you've had both of
I'm feeling great. Right. I just turned 58 and I'm and I feel I'm in remission. I have quality of life and
great.
I worked for the Cancer Association for 10 years and so now I'm spending time with me.
Right.
With me. Yes.
Dr. Makwa, before we run out of time in this segment, just briefly tell us about the programs that your department has, specifically your directorate.
Thank you very much. I think, let me start that by saying I'm very humbled to have the people that I work with and very closely sharing the studio with them. I think the partnership goes a long way. That's the first thing that we did with government and my directorate in particular. Because I think what we've realized is for the first time in South Africa when the breast cancer policy was approved in 2017, we've realized that we need to respect the space, that there have been people who have been in a space, who've been traveling the journey, who have done a lot of issues around it. We need to be in partnership with them. That's the first thing that we did. So that, for me, it's what made us to have some milestones that we are currently having for now. We're working very closely with them. So we don't even choose whether you're a big organization. We move all the way from big cancers to individual spaces. We use their experience. And most of the concepts that we've put in our department is actually some of the tested evidence-based things that they're already doing. We're talking of navigators, we're talking about breast advocates, we're talking about, so we're building around already what has been proven to be working on the ground. So that's the strength of us as department having the whole team working with us. So that's the one thing that we did. But I think the other thing that became very obvious when we started implementing the policy was that for a long time, I think breast cancer has been locked up in a certain corner under the name of specialty, and most people were left out. And that's where you would get all the comments that most patients who have been diagnosed will tell you about. Very nasty remarks of, you are stage whatever, you're left with so many days to live, all sorts of funny things. So we said, okay, let's step back. I think for this year in particular, we said we need to step back and now focus on our own healthcare providers.
Okay.
So
I think it's a good point for us to just have a short break. We'll come back in no time. Please stay with us.
It might not be a lump. It might be puckering, dimpling, breast or nipple changes, swollen glands, or yes, it might be a lump. Breast cancer is the most common cancer among South African women. So it's important to examine your breasts on the same day every month, 7 to 10 days after your period. If you no longer have your period, choose a day that's easy to remember. To do a proper breast self-examination, follow these 3 easy steps. In front of a mirror, check for any visible breast changes in 4 different positions. First, with your arms at your sides, then overhead, then firmly pressing your hands on your hips, and lastly, bending forward. Lie down on your back with a pillow under your right shoulder and your right hand under your head. Starting below the collarbone, make small circles by pressing down, moving clockwise towards the nipple. Remember to check under the armpit. In the shower, check your breast with the soapy left hand and fingers, using the same technique as lying down. Always repeat these 3 steps on both sides. Tell your doctor if breast cancer runs in the family. After the age of 40, make sure you have a mammogram every year. Cancer care centers offer clinical exams by professional nurses. Early detection can save your life.
Early detection can indeed save your life. We're still with Professor Carol and Ben and Dr. Manala Makua. We're now joined by another special guest who is a breast cancer survivor herself and is a government campaign ambassador. Rahab Zulu, welcome to Health Talk.
Thank you.
Right. Perhaps let's stay with you. We just had all of these inspiring stories from people who've survived breast cancer. Tell us your story. When were you diagnosed with breast cancer?
So I was diagnosed in 2017, October initially, and I had a stage 3 at the time. And I went through the process, chemotherapy, mastectomy, which means removal of the breast. That was the left breast that was involved. I did not have reconstruction because I still had to do radiation. And thereafter, I was on remission for about a year. I also received trastuzumab, Herceptin, 17 injections of that.
Okay, so let's take a few steps back. What symptoms did you see? Did you notice? What is it that said to you, hey, there's something going on, or let me go and see my doctor?
Correct. So I did not feel a lump, as it is usually told that you will see a lump if there's something in your breast. Unfortunately, in my case, I didn't see a lump. There was mass on the breast. The breast was hot. The breast was painful, and the armpit as well. There was something growing in the armpit, and I took upon myself to find a place where I can have this checked up, and I found a place. And core biopsy was done. Unfortunately, it was breast cancer, and not only breast cancer, but it was the aggressive breast cancer, which is HER2 positive.
All right, okay. So where are you now? This was on the left breast.
Left breast, correct.
Yeah. And you went through treatment, and yeah?
Yeah. So in terms of where I am now, so I've been on remission for a year. So unfortunately, in December last year, I felt on the supraclavicular lymph node, I felt a thickening there. And right away, I wrote an email to my oncologist and reported the matter to say, I've got this, that is swollen. And she said, come see me quickly. And I went in. As I went in, ordered biopsy, unfortunately, it was still breast cancer that has spread to the lymph node, supraclavicular lymph node, which then suggests that it's stage 4. And I think because it was that, I had to go back to chemotherapy, which I'm still on. That's where I am now. I do chemotherapy every week. It's a systemic chemo because once the cancer has spread to this lymph node, which is at the lower of your neck, it then suggests to be somewhat stage 4. Fortunately, when I did the CT scans to check how far is the cancer progressed, it has not yet gone to the other organs of the body. But that doesn't do away with the fact that it's stage 4. And that doesn't mean that it's a death sentence.
All right. I like the last thing that you said there. All right, just hold it there. We'll come back to you just now. Let's take V. Govender from KZN. V, welcome to Health Talk.
Hi, sir.
Hello, welcome.
Thank you.
You can go ahead. Do you have a question or something to share with us?
I have a question.
Right.
My husband has a lump just below his nipple, and I think he has lumps throughout his body. But just yesterday, he said the lump below his nipple is starting to pain. Is there any concern for worry?
Yeah. All right. Let's hear what Prof says. Yeah.
So thank you very much for that call. And if I gather right, your husband's got a lump on his breast. It doesn't have to be a cancer. Yeah, there's Albert Lutuli. They're very good government hospitals and private hospitals. He must go for an ultrasound of his breast, and then they must do something called a core biopsy. It can just be a male breast called a moob, and that's related to many things. But like we've mentioned earlier, you can get male breast cancer. So he's got a symptom and he's got a sign, and we should pick it up.
All
So
right.
thank you so much.
Okay. So here we're talking, I mean, obviously we've listened to Rahab's story here. I'm going to come back to you and ask you what being a government ambassador, entails. But let's come back to screening and prevention. We've played that clip that shows people what steps to follow in examining themselves. But let's talk about, screening, mammograms. Who should have a mammogram?
So both our ladies who we've spoken about earlier have fallen under the age of screening, and they haven't presented with masses. They presented with red hot inflamed breast, which is a feature of an inflammatory cancer. It's HER2 and Joanne. So what do you do for screening? You access a medical service where a doctor can examine your breast, and you tell them if there's a concern that you want a radiology investigation. An ultrasound if you're under 40, a mammogram if you're over 40. And you don't need to go for your mammograms every year. In America, they do their mammograms every 2 years. In the UK, every 3 years. It's about health economics. So it's about accessing and checking regularly. And if there's a change, as we heard in the clip from the last lady, she went to a gynae in March, and then in the end of the year she felt something, so she accessed the services. Then you get the right biopsy, the needle biopsy, to find out what it is. So the breast drains to the lymph node. So whereas we're quick to say stage 4, both this lovely young lass and Joanne have a similar type of cancer, HER2 positive, and we know those cancers, because we have a target for them, that people can last for many, many years on their treatment. But I'm very pleased that you advocate oncology.
Okay.
Thank you.
Dr. Makua, I mean, there's clear differences between what happens in the private sector and what happens in the public sector in terms of screening and mammography and so on. Are there perhaps protocols that are followed in the public health sector?
Yes.
Or should there be?
They are. They are. I think, like I've indicated earlier on, that we've worked very closely with the team that is on the space. And luckily we have the team that is working both in the private and the public sector. And again, let me pick on what Prof said, to say it's about health economics. And I think you know the dynamics of our health situation of 86% via the 14 and on all that. But I think what we're doing is we're trying to target messaging. Sometimes it's confusing if you give a blanket message. When the message of a mammogram goes out there in the public, they expect that from the public sector, yes, you just wake up in the morning and walk in a facility and say, I'm requesting a mammogram, or you just get to know about it and then get there. We actually saying it's not necessary. It needs to be indicated. You need to have a reason why you have to have mammogram. So that's the stand for the department. But we also say, there are people that are at high risk, let me say higher risk than others. We may be all exposed, but then the risks levels obviously. But the ones that are at a higher risk, we've got a protocol that clearly defines. With the familial history of that, there are exemptions, because we do know that when it gets to them, it tends to be aggressive, it tends to progress faster, it tends to manifest in a different way, which is not a normal traditional way of a lump or anything. So there are exemptions. So it's not a blanket statement. So we do have protocols. I think even the issues of where do you get it? I think from government we're trying to say we shouldn't think of, I think Prof also touched on it, to say we're trying to take down the service of breast care at a lower level, so that we leave only cancer cases to go up in the higher spaces.
And I wish we had so much time, but Dr. Makua, I thank you so much for your time. And Rahab, I was going to ask you about what your job entails as an ambassador, but I would imagine it's more about awareness, but unfortunately we don't have time to get to that. Thank you so much for your time. Before you go on a break though, we have Parnisha on the line from Gauteng. Parnisha, welcome.
Hi, good morning. How are you?
We're good. How are you, Parnisha?
I'm good, thank you. I have been a patient of Prof last year.
Right.
And I'd like to just say thank you to her.
Okay.
I think with her guidance and all her compassion, I wouldn't have been able to get through what I have been through.
Okay, wonderful.
So this call is just to say thank you to Dr.
Okay, well, thank you for that wonderful, positive call, and I'm sure she appreciates that. Time for another quick break. When we come back, we'll wrap up our show now talking about treatment. Please stay with us. Welcome back. We're talking breast cancer with our guests. We've had Prof. Carol Ann Ben, HOD at the Helen Joseph Breast Clinic, and we're now joined by two other guests. First, Dr. Gulza Malik, who is a specialist clinical and radiation oncologist based in Parktown. Welcome to Health Talk, Dr. Malik.
Thank you very much for the invitation. Nice to be here.
Right.
And good morning to SABC viewers.
Right. And of course, we have Dr. Mulefi Bulefi, who's a general practitioner and founder of an organization called Genesis. Welcome to Health Talk, Dr. Mulefi.
Thank you.
All right. Perhaps let's start with you and talk about, we're talking treatment.
Yes.
Just let's talk about the general principles of treatment.
So I think our people who were on brought up a whole lot of issues. So firstly, I want to say that there's no such thing as an emergency. You never rush into your treatment. You discuss everything in a multidisciplinary environment.
Right.
You do not need to take a breast off to manage a breast cancer, except in very few incidences and in patient choice. So the principle is to take the cancer out with a clear margin. I always say surgeries for blondes, and to do radiation oncology. We show that breast saving and radiation actually has equal, if not better, survival than taking a breast off.
Yeah.
So often when people talk about these recurrences and stuff, it's often on the initial time they've missed out on something such as radiation.
Right.
Oncology is the umbrella. No one died of cancer in their breast, it's its ability to spread.
Right.
So oncology is an umbrella of different types of cancer treatment,
Right.
which are divided into targets, the Herceptin that you mentioned, trastuzumab, that we've had 2 patients on, the endocrine, which is hormones and long-term treatment. It's like a contraceptive to prevent cancer coming back. Cytotoxics, which is what people commonly understand as chemotherapy, and today we have a field of immunotherapy. So it's critical that you understand when you need those, and the local treatment is surgery and radiation. We have exciting things coming out. So Joanna, who was on your clip earlier, will probably in a month or 2 freeze an area. You can freeze areas of cancer.
Of course, we don't, you know, I mean, obviously it'll get too technical if we were to say who gets surgical treatment and who gets what. But Dr. Malik, would just take us through what you deal with in terms of, you know, treating breast cancer patients.
Yeah. I deal with radiation and chemotherapy, hormone therapy as well.
Right.
Radiation is a form of treatment where high energy beam is delivered to the breast area, chest area, to kill breast cancer cells.
Right.
So it is basically not really heavy treatment like chemo or surgery.
Right.
It's mild type of treatment.
Right.
Only thing is that it sometimes lasts from 3 to 6, 7 weeks, and sometimes we give it intraoperative treatment as well in types of in terms of electrons.
Yeah.
So which is only done once, just only once.
Yeah.
The main thing is that it is very convenient, but it's done only for early cancers.
Right. Right.
And basically it is little bit patient get tiredness with the radiation therapy, and sometimes skin becomes a little bit pigmented, and just that's not really too much here, you know.
Yeah.
So it is very, you know, that convenient treatment, not really a big problem.
Right.
And then next is chemotherapy.
Chemotherapy, yeah? All right.
Yeah.
So how is this chemotherapy given then? I believe that the cycles and so on. Just take us through that, yeah?
Chemotherapy is a form of drug treatment where powerful chemicals are given by, usually by drip, and you know, to kill breast cancer cells. Either they are, you know, that obvious, or they are hidden cells, you know, in the body. So it's given in terms of cycle. It's given in terms of the combination of drugs. Usually 2 or 3 drugs are given, and sometimes only 1 drug is given as well.
Yeah.
So patient comes there, and then patient will have blood tests. There are some side effects, and like hair loss, nausea and vomiting, and blood count go down as well, tiredness, these type of things. But these are manageable. Not, you know, serious side effects are really very, very uncommon.
I suppose the very well-known side effect is this So hair loss that everybody talk about.
Yeah, hair loss that
Yeah.
we basically sometimes we do it ice hair to prevent it, but problem is it's temporary thing. It's not really permanent. So many people they use wig as well. So it is not really permanent. So we should not worry about that. The benefit of chemo, radiotherapy, surgery are huge. And the side effects are minimal nowadays. And all these drugs are tested in clinical trials before they become available to the patients.
Talk about drugs, we're going to come back to the issue of access. But let's bring in Dr. Malifi. Dr. Malifi, I mean, treatment of breast cancer oftentimes, not in fact only treatment, but just from diagnosis, has some sort of impact on, body image, I believe you've done quite a bit of work around, body image, insofar as breast cancer is concerned. Just take us through that.
Thank you. Our general overview is that a lot of care, as we said earlier, is not just in hospitals, in oncology practice, or, but it's actually outside care. Outside care, they link up with going out into palliative care and so on, to see what has happened to people after they received that initial treatment, how they're doing with adherence to further treatment that they need to take, how they're doing to monitor their side effects of the treatment, and how are they monitoring their quality of life, because it is quite crucial to have to say, well, you just had your treatment, but you don't quite, monitor what actually happens thereafter. So body image is actually quite important to us because we believe it encompasses a very robust concept that actually talks to the patient about what the patient actually feels, about what cancer has done to them in terms of the disease itself and in terms of all the treatment that they've received. We've actually listed quite a number of topical areas, starting from the physical effects of of treatment, to the psychological impact of the treatment, to a whole lot of other not so evident consequences of treatment, affecting people's fertility, people's sexual life, and a whole host of other things. So, and there's quite a few programs that we put down, simple programs as to how to engage the general public in our outdoor, to consumer, campaigns to get people
who are
to
these?
know.
Who are they directed at? Is it other healthcare professionals, or is it the patients themselves?
Yeah, it's the patients themselves. I mean, our model is to work with, help other community health workers to be able to do work with us, and extend our outreach out into peripheral areas. But we feel it's very important as well to have the ordinary volunteer through our peer educator program that actually talks to the person next door. And then, of course, very key, coming out of a general practitioner environment myself, we understand what actually happens in the GP, network spaces, to get into relationships with the primary care, physicians throughout maybe the breadth of the country, to try to see how we can not be able to extend this vision.
But do you have your own network of professionals that deal with this body image?
Well, not quite that we have a network per se. All doctors are independent, as you know, but we go out there to engage into partnerships and collaborations because we believe together we can be able to overcome this animal called breast cancer.
Obviously, breast cancer treatment is a multidisciplinary type, as we had. We don't have a lot of time. That's your last 30 seconds?
Last 30 seconds, that's the concept of survivorship. We are here to treat, but the person as a whole. So know your body, go for your test, don't be scared to go through your treatment, and then the concept of survivorship, managing you and your life thereafter is critically important. And together we can beat this.
Okay. Dr. Bali?
Yes, I agree with that. Basically, knowledge is power. So you must know breast cancer, risk factors, family history. So a healthy lifestyle is important. The important thing is that it is very curable. Cancer is not really death sentence. Earlier is better, prevention is better, and we can fight. There's no problem nowadays. Breast cancer can be defeated.
We believe patient involvement is key. The patient has got to be empowered. Self-management is critical. And therefore, that's why we believe this whole concept of what we call shared decision-making is critical, because it's got to involve the patient in whatever happens to them.
I'm afraid that's all the time we have. Thank you so much for your contribution, and thank you for your time. And then for you folk at home, thank you so much for watching. We're back with you again in a week's time. Same place, same time, and until then, please do take care.
Thank you.